Welcome to this Step 3 review on headache management, brought to you by Roadmap to Residency. Headache questions are everywhere on this exam, and they are unusually beatable because the writers reuse the same handful of stems over and over. Our goal today is not to teach you all of headache medicine. It is to show you exactly how these stems are built, which planted words decide the answer, and which distractors are traps. Keep your question bank and a solid review resource open alongside this video because these patterns stick only when you drill them. Let us get started. Here is our plan for today. First, we will sort the primary headache disorders using only the details in the stem that actually decide the answer, because the rest of the vignette is padding. Second, we will get abortive and preventive therapy right, which is the single most common decision these questions ask you to make. Third, we will nail down when to image and when to send the patient to neurology, since both are favorite trap answers. Along the way, we will work through several practice questions and reason through every option. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Strategy 1 is to let the stem sort the diagnosis for you. Headache vignettes look long, but the diagnosis turns on a few planted words, and the rest is there to slow you down. Train your eye on 3 details: how long the attack lasts, where the pain is, and what the patient does during it. Hours to a day, throbbing on one side with nausea and sensitivity to light and sound, and the patient lying still in a dark room, is migraine. Minutes to a few hours, strictly around one eye, with tearing and a droopy lid, and a patient pacing in agony, is cluster. A bilateral pressing band with no nausea and no real disability is tension type. The patient's behavior is the detail most people skip, and it is the fastest way in. Lying still means migraine. Pacing means cluster. Strategy 2 is recognizing that the real question is almost always abortive versus preventive. 2 answer choices will both be legitimate migraine drugs, and only one is right for this patient. So read the last line first to find out whether they want you to stop the attack in front of you or reduce attacks over the coming months. Then go back and hunt for frequency, because frequency is the detail that settles it. An occasional attack needs an abortive drug only. Roughly 4 or more headache days a month, or attacks that stay disabling despite a good abortive drug, or a patient using abortive medication on most days, means the question wants prevention. Here is the rule that will win you points. When the stem takes the trouble to tell you how many headaches per month, that number is the answer key. Writers do not include a frequency by accident. Let us make the abortive choice concrete. For a mild to moderate attack, a non-steroidal anti-inflammatory drug is the reasonable first choice. For a moderate to severe attack, or when simple analgesia has already failed, the answer is a triptan. If the patient lands in the emergency department, the pattern these questions reward is an intravenous dopamine-blocking antiemetic with fluids. Now the 2 traps. The first is a triptan handed to a patient with uncontrolled high blood pressure or known coronary disease. Those are vascular contraindications, and whenever the stem gives you a cardiac history or a high blood pressure reading, that detail exists to make the triptan wrong. The second is the patient taking abortive medication on most days who now has daily headache. That is medication overuse headache, and the answer is never to add another abortive drug. Here is our first practice question. A 28-year-old woman has headaches about twice a month for 2 years. Each builds over an hour, throbs on the left side, and lasts most of the day. She feels nauseated, turns off the lights, and lies down until it passes. Ibuprofen no longer helps. Her blood pressure is normal and her neurologic examination is normal. The question asks for the most appropriate next step. Notice how much of this stem is planted detail. Ask yourself what the diagnosis is, whether anything here is a red flag, and how many headaches she has per month. Pick your answer, and we will reason through every option on the next slide. Let us break it down. First, lock in the diagnosis. One-sided, throbbing, lasting most of the day, nausea, and the dark, quiet room. That is migraine, and every feature was planted for you. 2 years of stereotyped attacks with a normal neurologic examination and normal vital signs means no red flag anywhere in this stem, which kills the magnetic resonance imaging choice immediately. That choice is the overkill trap, and it appears in almost every headache question. Now count the days. Twice a month is well below the threshold for prevention, so daily propranolol treats a problem she does not have. High-dose ibuprofen around the clock is wrong twice over because simple analgesia has already failed her and because that is how you create medication overuse headache. She needs a stronger abortive drug, and with a normal blood pressure and no cardiac history, the triptan is safe. The answer is sumatriptan for acute attacks. Here is our second practice question, and the tone changes completely. A 44-year-old woman comes to the emergency department after a headache began abruptly while gardening and reached maximum intensity within seconds. She calls it the worst headache of her life. She vomited twice. Her temperature is normal. Her blood pressure is elevated. She is awake and answering questions, and her neurologic examination shows no focal deficit. The question asks for the most appropriate next step. Read those first two sentences again because the writers chose that phrasing deliberately. Pick your answer and we will walk through all four choices. Let us reason through this one. First, spot the red flag words, maximum intensity within seconds and worst headache of her life. That is the thunderclap pattern, and it is the most reliably planted phrase in all of headache questions. It means you must rule out a subarachnoid hemorrhage. Her normal neurologic examination is reassuring, but it does not erase the red flag, so discharging her is unsafe. Giving sumatriptan is the trap for anyone who pattern matched on the vomiting and jumped to migraine. Now the harder distinction. Lumbar puncture is genuinely part of this workup, so it feels correct. But the question asks what comes first, and imaging comes before the needle. The scan is fast, most sensitive early after a bleed, and it tells you whether it is safe to proceed. Here is the lesson. When two choices are both part of the correct workup, the question is testing sequence, not knowledge. The answer is non-contrast computed tomography of the head. Let us consolidate when to image, because this decides a large share of headache questions. The default is no scan. A stable patient with a stereotyped headache pattern, normal vital signs, and a normal neurologic examination does not get imaged, and the scan is the classic overkill trap this exam plants relentlessly. When the stem carefully walks through the red flags and tells you each one is absent, that is the writer signaling that imaging is not the answer. Now, the red flags that flip it, sudden maximal onset, a focal neurologic deficit, a new headache after age 50, fever with neck stiffness, a headache that is worse lying flat or that wakes the patient from sleep, a headache pattern that has clearly changed, a patient with cancer or immune suppression, papilledema on the eye examination. One red flag is enough to make imaging the answer. No red flags means no scan. Here is our third practice question. A 35-year-old man has migraine without aura, confirmed 2 years ago. He now has 8 headache days a month, and each attack keeps him home from work despite sumatriptan, which reliably relieves his pain. He has no other medical problems and takes no other medications. His vital signs and neurologic examination are normal. The question asks for the most appropriate next step. 2 details in this stem are doing all the work, and one of them is designed to pull you toward the wrong answer. Choose your answer, and we will reason through every option. Let us break this down. The number is the answer key. 8 headache days a month, with attacks that stay disabling even though the abortive drug works, is the textbook setup for starting prevention. The diagnosis is established. The examination is normal and the pattern has not changed, so magnetic resonance imaging is once again the overkill trap. Now the key distinction. Increasing the sumatriptan dose is the tempting distractor, and this detail decides it. The stem tells you sumatriptan reliably relieves his pain. The abortive drug is not failing. Frequency is the problem, and no abortive drug fixes frequency. When a stem goes out of its way to tell you a treatment works, it is closing that door for you. Neurology referral is premature because starting a first preventive drug is squarely your job. The answer is Topiramate. Here is the exam day pearl that ties this together, and it is about referral. On this exam, you are the physician, and referral answers are planted to see whether you will hand off work you should be doing yourself. Diagnosing a primary headache, starting an abortive drug, and starting the first preventive drug are all yours. If the stem has not shown you a concrete reason the specialist is needed, referral is wrong. So when is it right? Refer when the stem hands you the reason. 2 or more preventive drugs have failed at adequate doses. The diagnosis is still unclear after a reasonable workup. There is an abnormal neurologic examination, or an abnormal scan, or the headache is refractory despite appropriate care. The habit to build is simple. Before you pick referral, point to the sentence that justifies it. If you cannot find it, the answer is something you should be doing yourself. That wraps up our review of headache management for Step 3. Remember the core moves. Sort the primary disorders on duration, location, and what the patient does during the attack. Read the last line to see whether they want abortive or preventive therapy, then let the number of headache days per month decide it. Default to no imaging unless the stem plants a red flag, and remember that thunderclap means the scan comes before the lumbar puncture. And do not refer until the stem gives you the reason. Lock this in by drilling headache questions in your question bank under timed conditions and reading every explanation, even on the ones you got right. Visit roadmap-to-residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.